Well, it is 5:01. We're going to get started. So, good evening. It is my pleasure to welcome you to the fourth and final session in the Race Health Equity virtual conference series titled Achieving Health Equity. My name is Anne Marie Knight, and I serve as the Vice President and Chief Diversity Officer for UF Health Jacksonville. But I have the distinct pleasure this evening to welcome you on behalf of the Jacksonville Nonprofit Hospital Partnership, a consortium of the nonprofit hospitals here in Jacksonville, Florida. Those hospitals include Ascension St. Vincent's, Baptist Health, Brooks Rehab, Mayo Clinic, and UF Health Jacksonville. The partnership, the first of its kind in the state of Florida, collaborates on assessing the health and wellness of the community and then collectively works towards to work collectively to address gaps in access to health resources and other activities to promote healthy lifestyle and well-being. It is our goal to continue working towards eliminating health disparities, ensuring health equity, and creating opportunities to empower our fellow citizens as they address health and well-being challenges that are influenced and or the result of disparate opportunities due to race or ethnic differences. Before we get started and in preparation for the session, I'd like to share a couple of housekeeping steps that will ensure the most optimal experience for you during this session. First, we recommend changing your speaker view for the discussion. We recommend changing to speaker view for the discussion. This will offer the greatest visual engagement experience. Second, please don't hesitate to submit questions through the questions and answer button on the bottom of your screen as soon as those questions come to mind. At the end of the session, it is our goal to address as many of the questions as possible. If we are unable to get to your question, please be assured that all questions and answers will be shared in the coming weeks following this session. For the healthcare professionals in attendance today, CME and CEU credits are being offered for the session. In order to earn the credits, attendees will need to keep an eye out for an email in the next 48 hours and follow the instructions that are provided. Now it is my pleasure to introduce our moderator for the evening. Carl Lavender Jr. serves as the Chief Equity Officer at the Foundation for a Healthy St. Petersburg here in Florida. He guides community investments, including grants, partnerships, and program design in alignment with the Foundation's mission of racial and health equity. Carl works with his president and CEO, Randall Russell, to plan, assess, and direct Foundation strategy and resources to advance race equity to achieve health equity in Pinellas County. He serves as a resource and sounding board for members of the community who are seeking the most effective and impactful ways to build a race equity movement in the region. Carl's previous roles include at the Foundation, Senior Director of Programs and Chief Engagement Advocate Officer. He has made a notable career in leading nonprofit organizations in Pinellas County for the past 20 years, and also served in high-level community advancement and fundraising positions in Chicago and Cleveland nonprofits prior to that. Mr. Lavender holds a bachelor's degree in educational leadership and administration from the Ohio State University and a master's degree in human services, nonprofit organizational management, cum laude, from Springfield College in Massachusetts. Welcome, Carl.
Thank you, Anne-Marie, and good evening, everyone. Good evening and welcome to this that will promise to be a robust discussion about health equity. And we come to this moment at the end of what is considered by many a very challenging year. But we end this year together to learn to lead, and together to share insights into what is the best way to move into the next year and into the next decade. We can all agree it has been one heck of a journey this year, but I'm glad we're here together. We have a distinguished panel to share with you who will open up the window and allow good information to come into your minds. You need to leave here expecting to do better and best in your communities and in your industries. We have Dr. David Ansel and Pamela Mitchell-Boyd. Allow me a few moments to introduce these incredibly important leaders in this space. David Ansel is the Michael E. Kelly Presidential Professor of Internal Medicine and Senior Vice President, Associate Provost for Community Health Equity at Rush University Medical Center in Chicago. He is a 1978 graduate of SUNY Upstate Medical College. He did his medical training at Cook County Hospital in Chicago. That's a tough job. He spent 13 years at Cook County as an attending physician and ultimately was appointed chief of the Division of General Internal Medicine at Cook County Hospital. From 1995 to 2005, he was chairman of internal medicine at Mount Sinai, Chicago. He was recruited to Rush University Medical Center as its inaugural chief medical officer in 2005, a position he held until 2015. His research and advocacy has been focused on eliminating health inequities. In 2011, he published a memoir of his times at County Hospital. It's called Life, Death, and the Politics at Chicago's Public Hospital. His latest book is The Death Gap, How Inequity Kills, was published in 2017. He's joined by a dynamic sister in her space. Pamela Mitchell-Boyd is Systems Director, Diversity, Inclusion, and Language Services at Amita Health. Allow me a moment. The undercurrent of all of Pam's professional experiences has been to champion and support socially vulnerable populations and to ensure that adults and children are compassionately provided with fundamental human needs such as housing, education, and healthcare. At Presence Health, as an organizational effectiveness consultant, Pam traveled throughout the healthcare system, working with executive teams to cascade the organizational strategic plan. The goal of this work was to ensure that regional and local plans were aligned with systems objectives, and the unique needs of each community were incorporated to address the essential health issues of each patient population. So important for today's conversation. Working now in diversity and inclusion and language services at Amita Health, Pam's focus is on enhancing the patient experience through culturally competent education, language services, as well as recruiting and retaining diverse talent in both clinical and non-clinical areas. Additionally, her focus is on determining areas of opportunity in health equity by considering the distinctive health needs of the communities served based on the social determinants of health. She has earned a certificate in diversity management and healthcare from the Institute of Diversity in Health Management, American Hospital Association. Pam earned her undergraduate degree in human development and social policy from the School of Education and social policy at Northwestern University, and a master's degree in social service administration from the University of Chicago. Wow, these are some dynamic people, absolutely dynamic. Let me say this, folks. In lieu of the fact that we have arrived here from various pathways in life, I like to begin a panel like this with this particular focus, asking these leaders to share 1 minute or so their racial autobiography. Why do I say that? When you look at health equity, race plays a critical role in determining pathways in health and health equity. And you bring to that conversation, that narrative, your own sense of place and space that begins with your identifying fully who you are in this moment and your value. Thus, I ask our panelists, wherever I go, to begin your conversation with your own racial autobiography. First, Dr. David Ansel, up to you, my friend. Share, and we'll go to Pamela. Ladies and gentlemen, Dr. David Ansel and Pamela Mitchell-Boyd.
Thank you. So good evening, everyone, and really thank you for having us tonight. This is a critically important conversation, not just in Jacksonville, but really around the country. So I usually start my talks off this way anyway, because I think people want to know where you're coming from. So I'm a doctor, I'm a hospital administrator, I'm a social epidemiologist, but I consider myself a human rights activist. And I'm going to tell you a little bit story about where I come from. On the left is my mother and my older brother, and you can see me on on the right-hand side there with a baseball mitt. That was not my skill set in life. But we were like the all-American 1950s, 1960s family. But the backstory was my mother came from Europe. Actually, my parents emigrated from England, but both of their families were in mainland Europe. And 2 weeks before my mother died, this picture on the right came to us on the internet, and it came from the archives of a Nazi soldier. That's my mother's grandfather being posed in front of tombstones with a yellow star on his arm. He was quite old at this point in time. We know the next year on a forced march, his family was trying to hide him, and the Nazis caught him, and my mother's cousin stood in front of him, and both of them were killed at that moment. And 2 years before this picture, my grandfather and uncle went to Poland to try to get them out, and he said, "I have to tend my flock." And that's the family story. So in Europe, my family in the last generation were victims of racism, mass incarceration, and genocide. But I grew up in this country with a different assignment. And it wasn't until I was 60 years old that I could really speak openly about racism. And I'll hand you more on that in a little bit, but I'm going to hand it over to my colleague, Pamela Mitchell-Boyd.
Thank you, Dr. Ansel. It is certainly a pleasure to be among all of you this evening and to talk about our journey. One of the things that has guided me in my life journey is, of course, my parents. And there's a little bit of a lag here to the slides. And so I'm sorry, I'm a little bit slow here, but these are some illustrations of my life. Both my mom and my dad were teachers. I'm from a suburb of Cleveland, Ohio, called Shaker Heights, Ohio, that was intentionally focused on integration. So in the 60s, 70s, and 80s, there was an intentional movement to ensure that Black families and white families lived and worked and went to school in an equal environment. And you see my dad on the right-hand side standing near a school bus. And he was actually responsible in the 70s working for the Cleveland public school system for enhancing desegregation. He was an assistant principal and then ultimately a principal. And so that kind of undercurrent lived in our house every day. My mom was an English teacher. She ultimately became a guidance counselor. So I have a slide in the center about Langston Hughes and Maya Angelou and Richard Wright and the Harlem Renaissance and James Baldwin, because those books were left all through our house and influenced the way that we thought. And that feeling has continued with the picture that you see on the bottom of the energy that both my parents are now deceased, but there's an energy that still lives to my son. And this journey that I'm on is a reflection of what I've received from my parents in terms of the importance of education, the importance of understanding our culture, our roots, and passing on all of that to my child. And so you see certain pictures of my dad and my son kind of looking alike. And that's the reflection that I need every day to ensure that I'm passing these values on to my son, especially as I'm concerned and worried living in Chicago, of making sure that my son is safe in the environment and accepted and included in the environment that we're training him to live in. So that's our journey, starting from my parents, moving on to my son.
Outstanding. Ladies and gentlemen, we now begin our presentation. Dr. David Ansel.
Well, I'm going to take you on a little personal journey again, my health equity journey. I'm going to talk to you about this fundamental reframing of how we understand health and healthcare And I'm going to pose the question to you: what if everything we thought was correct about health was wrong? And I'm going to lead us into COVID-19, racial justice, and wealth inequality, and some of the work that we've done in Chicago, like you're doing in Jacksonville, to bring the hospitals together, in the city together in an intentional way around racial justice. Could I have the next slide, please? So, you know, my parents and the values in my household were that if you saved one life, it was as if you saved the whole world. And community was very important for me. And I grew up in this during the civil rights movement in this country. And I knew that there were things going on in this country that were very similar that went on in Nazi Europe. In fact, many of the foundations of Nazism that led to the death of literally everyone in my the Jim Crow laws, the science of racism, of saying that one group is the foundation of and anti-Semitism, as well as the foundation of white supremacism. Because that I learned that the foundations of
Okay.
It looks
Pam,
like
would you
we may,
yes, exactly. We may bring him back in. But Pam, begin your slides, please, and then we'll see if we can get him back in.
sounds good. Let me advance. So I've had the pleasure of,
There he comes back.
Okay.
disappeared and now you reappeared. Isn't that
Yeah.
let me come
magical?
back.
Yeah.
Anyway, take me back. So that I learned in medical school that the foundations of American medicine were built on this framework of white supremacism. Just use this as just one example. This is from World War II as a poster, and the poster was meant to show GIs. They had to put the blood supply together to tell white GIs that if they got black blood, it'd be okay. But the whole foundation of American medicine, and even today, in some of our ways we calculate cardiac risk, or ways we figure out what somebody's kidney function is based in scientific racism. But as a human being, it took me to, I wasn't until I was about 60 in which I could clearly speak to white supremacism, which is a system that values people based on skin color and values whiteness and assigns privilege to it. And the system, I call it a system of oppression, white supremacism. It wasn't until I was 60 years old that I was able to speak about it. And I had to do a root cause analysis on myself. I really had to ask myself why. So when something goes wrong in a hospital, I was a chief medical officer, like someone comes in for a knee replacement and they get a infection in their bloodstream, you do a root cause analysis. And basically you ask yourself why 5 times. And the reason why you do that, it's really important to get to the root cause of a problem, because if you don't get to the root cause, you can never solve it. So I asked myself why 5 times. Here's a doctor whose family were wiped out in the Holocaust in Europe, grew up in the United States, came to Chicago, worked in black neighborhoods, took care of black and brown patients. Why did it take me to 60 to speak to the problem of white supremacism as a root cause? And when I asked myself why 5 times, first why was, well, I didn't really feel comfortable using the words. Well, why didn't I feel comfortable using the words? Well, really no one around me talked like that. Well, who were the people around me? Well, they were these nice people, that I worked with in the hospital. Well, who were these nice people? Well, they were all white people. And why didn't I want to disturb them? Why? Because they invited me in the room. And I realized that as a white man, I needed to speak about the problem of white supremacism and racism. And I thought back to my family in Europe being let off by the Nazis. And the way that I sorted it out was to say, it wasn't up for the Jews to complain about their treatment. It was really up to the good people of Poland and Germany to speak up. And that's why I, after many years, became more vocal in speaking about it, as what I think is a root cause of poor health outcomes. Next slide, please.
Sorry, there's a bit of a lag.
Okay, you never get there by yourself. So this is I called her Mrs. Bradley. It's not a real name, but I met her when I was an intern at Cook County, and we were similar. We were the same age. We both had come to Chicago, me from upstate New York, she from Birmingham. We lived literally a couple miles apart, and we still live a couple miles apart. She's still my patient. And yet, as a young woman, she had hypertension and diabetes, and that just seemed recalcitrant to my treatments. I said, I felt like the hapless conductor on a runaway train, and say, what is going on that her diabetes is so difficult? And I learned the story of her family and what happened to her and her family. She had a goddaughter who was, she had a granddaughter who was murdered in the alley. Her son died after an operation. She talked about the stores in her neighborhood, no grocery store, just corner stores with candy. She talked about living, she worked full-time in Chicago public schools, but had to make decisions between food and medications. And when I wrote the book, The Death Gap, How Inequality Kills, I was thinking about her. One day she said, the worst thing that could happen to me would be if I had a stroke and I couldn't talk. And one day I got called from my office, literally one floor down from my administrative office. She's in my office having a stroke. And despite having a life-saving stroke team, there was nothing we could do to get her speech back. She's still alive, loving family, third generation. But I said, there's something that's not right in the way that I've learned medicine and the skill sets that I need to help patients like Mrs. Bradley. Next slide, please. So I asked the question, like I mentioned, what if our whole notion of health and disease is wrong? So from the time of the Greeks to the mid 1800s, people felt that the cause of disease were odors, bad odors, or ill humors. This is from England, and this is from the pandemic in the mid 1800s, one of the first world pandemics after the plague, and it was cholera, introduced by India, brought in through travel and sailors around the world, and introduced into the water system. Cholera is a bacteria, but in those days, they didn't know that, because the notions of disease passed down by the Greeks and Romans was that disease was called by these, they were called miasmas, bad smells. And there was an anesthesiologist. He was the anesthesiologist for Queen Victoria and delivered her baby with a C-section. He knew it couldn't be things you breathe in. So he did a study of all the cholera cases in this area of London, and that they're all in red. And he found that they were all centered around this one pump that pumped water from the dirty Thames River, and people took home to cook with and drink. And everyone who had cholera, all these red dots are deaths, think COVID, came from water from that pump. And he convinced the city officials to take the handle of the pump off, and the cholera rates went down, though they never once believed that, as he thought, something in the water was causing disease. A few years later, Louis Pasteur, a French chemist, came up with the germ theory of disease that carries us now. But what if everything we learn in medical school and nursing school isn't correctly right, and there's something else that's making people sick? Next slide, please. So in 2005, in 2016, I went to my CEO and said, I don't want to be chief medical officer anymore of a hospital. I think that we were just in the process of changing our mission from being the best in healthcare to improving health. And I was the chief medical officer who got Rush, we're literally got ranked first in the country in quality. And we're a US News and Report honor roll hospital. But I gave up that job because I said we could improve quality all we want in this box, in this hospital, and never get to the root cause of what makes patients like Mrs. Bradley ill. And I presented this map to our board, and it goes like this. If you live in the Loop, downtown Chicago, a neighborhood of concentrated white affluence, you could live to the age of 85. And in some communities, they're 90. If that were a country, it'd be ranked first in the world. Think Japan or Monaco. But go 7 stops down the blue line, that horizontal line right in the middle, to the West Garfield Park neighborhood of Chicago, literally 3 L stops from my hospital, and life expectancy plummets to under 69. And my CEO at the time said, when was the last time in American history life expectancy was under 69? And you'd have to go all the way back to the 1950s. 7 L stops, 7 decades of life expectancy. So I wanted to pose a thought question for you. Imagine if everyone in America took statins, which are the drugs for cholesterol, that bind exquisitely to the receptor for bad cholesterol in the cell. Guy won the Nobel Prize for coming up with that receptor. You can't get a better drug to target a receptor better than statins do for cholesterol. If everyone in America took a statin for high cholesterol, you would add 20 minutes onto the life expectancy of Americans. But imagine if we spent our time digging into what's making people in Garfield Park sick. And I will posit to you that is the neighborhood conditions, the conditions under which people work, live, play, and age that make all the difference in the world in life expectancy. Next slide. And it's not just Chicago. So here's Jacksonville life expectancy, right where you're all standing. The extremes that we see in Chicago are seen in every city in the country, actually every place in the world. They're not unusable, but we've never been trained to think that neighborhood conditions can improve health. Next slide, please. So here's a story I tell every time I give this talk. If you're a 16-year-old teen on the west side of Chicago, this teen has a little bit more than a 50-50 chance of living to the age of 65. And you can put in the chat, or you can think in your head, cause of death. And of course, a lot of people, when they think a teenager, young man on the west side of Chicago dying early, you think of violence. But it's not just gun violence. There's 5 leading reasons why people, not just on the west side of Chicago, in Jacksonville as well, die prematurely. And number 1 is cardiometabolic disease. And number 2 is cancer. And those 2 causes account for more than 50% of the premature mortality in neighborhoods like Garfield Park. And yet people think it's violence. Next slide, please. And I say, yes, it is violence. It's structural violence. And this is a picture of that neighborhood, not far from that neighborhood. That it's structural because it's designed into the way that our laws have been created, how our public policy is done, how our policies, our procedures, how we police, what we tolerate in housing, what we tolerate in schools, what the neighborhood environment is, et cetera, et cetera. So structural, and it's violent because people are harmed as a result. And structural racism is a form of structural violence. And it's a root cause of poor health. So I talk about that inequality kills, that we have an epidemic of inequality and inequity, and it kills just like any virus. Next. So it's critically important that white people in particular, but all of us in general, speak about racism, and naming racism as the root cause, because it's a form of oppression, it's an affliction People in Garfield Park on the west side of Chicago it just didn't happen overnight. It happened over many, many years, but it's an act of affliction, just like I say, an infection or anything else. So what do we mean by racism? Differential access to the goods, services, and opportunities of a society by race. Opportunity deprivation. It's an act of violence. It's a system of structuring opportunity and assigning value based on how someone looks, skin color. And for those who are white, like it was for me, I worked hard my whole life to become a doctor. I became a leader. I practiced what I did. But it's difficult to recognize a system of inequity that privileges us. There's an ownership issue here. We've got to take ownership for it. It's been around for hundreds of years, but it's critically important that we name it. By the way, you got 1 point in the world for naming the problem. So it's not such a big deal, even though we haven't named it. You get 100 points for solving. Next slide, please. And health equity really has to do with the inequity in power, money, and resources that give rise to the inequities in daily life that lead to health differences. As a doctor, as someone who went into this business to save lives, there's nothing better I can do than focus on the conditions in neighborhoods that oppress people and lead to low life expectancy. Next slide, please. So now I'm going to turn to the current moment. People were surprised. The great equalizer. So on the upper left side, this virus is killing our people. In Chicago, of the first 100 deaths, 72 were in Black people. People were surprised at the great equalizer. None of us have immunity, and yet it differentially impacted and still impacts Black and brown people in the United States. By the time this is over, 1 out of every 500 Black people will have died in the United States, will have died of COVID. And for those who you were surprised, shame on you for not understanding that all the COVID did was plant its seeds in the chasms and social fault lines that pre-existed in a racialized society. And I will say positive in one other thing, and we can have this in discussion, that our lack of a national response was in part because it differentially affected Black and brown people. And then we all suffer as a result of that. But then you had the murder of George Floyd. And for the first time, all of us in the United States had to witness a public lynching where the victim narrated his own murder while the policeman was on his neck for 8 minutes and 46 seconds, to understand that the pandemic in this country was not just a virus, just like the cholera in England. The pandemic here is racism. Next slide, please. And there's a third part of this pandemic now, which is the unemployment. This is in Austin, Texas, food lines. By the way, it affects everybody, Black and brown and white people. But our failure to help those who've been most marginalized has put us all at risk. Next slide. So where you live dictates when you die across the world, but particularly in the United States. This is from the economist Raj Chetty. He's going to win the Nobel Prize. You can watch his YouTubes. He's terrific. But basically this says, no matter where you live in the United States, if you're in the top 5% of income, you're going to live a long, healthy life. In fact, until the median income, right in the middle there, people live just about the same no matter where they live, even though there's a gap between life expectancy between the richest and the median. But look what's happened to it. You get down to poverty. Public policy makes a difference. Where you live dictates when you're going to die, not just in Chicago and Jacksonville, but all around the country. So public policies like the Affordable Care Act, the expansion of Medicaid that just passed the referendum in Florida, make a difference in who lives and who dies. Next slide, please. So in Chicago, when the first disproportionate Black deaths occurred, the mayor pulled together a racial equity rapid response team that pulled healthcare providers, the mayor's office, group that we're going to talk about a solution, Westside United, we're going to talk about that in a little bit, pulled it together, this racial equity rapid response team with the community. I co-chaired the provider group. And after George Floyd was murdered, all of the providers, including Amita Health, where Pam is from, decided to sign on to a statement, a public statement. It was in the Chicago Tribune and the Sun-Times. It's undeniable racism is a public health crisis. And we made a series of commitments of what we're going to do about it. This has since been affirmed by the Healthcare Anchor group, and we're putting together a racial equity progress report to hold ourselves accountable to racial equity. That pilot is being piloted right now. So there are things we can do. And I'll just focus on the 4 pillars of the progress report: education, prevention, testing, treatment, and supportive services. These are 4 pillars of the racial equity rapid response team that was put together by the city. And Chicago has had one of the best urban responses in the country because we have community with providers, with the mayor's office, all around the same table. And Pam and I have been around that table since April. And while we've had the surges like everyone else, we've managed to control it. These are the joint statements we said that we were going to address, and we're going to address it in this health equity scorecard that's being piloted. And next slide, please. So I'm going to end on this note and hand it over to Pam. You know, when we took this to our board back in 2016, and for the first time in Russia's 180-year history, in our community health needs assessment, named racism and economic deprivation as the root cause of the poor health outcomes in our neighborhoods. And when we said, what can we do about it? We decided we were going to become an anchor institution and that we were going to hire locally and create career pathways to wealth, purchase locally and support local businesses. We were going to invest locally, take money out of our endowment and invest it on the west side of Chicago, neighborhoods of about 600,000 people. And we were going to volunteer locally. We knew we couldn't do it alone. And so we went around to all the other West Side institutions, Amita, and you'll hear from Pam in a second, Cook County Health, U of I, Lurie Children's, Sinai Health System. And we said, would you join us in a collaborative? And then we asked the community to join us in sharing power. It's a racial health equity collaborative, and it's aimed at addressing the social and structural determinants of health, economic vitality, educational outcomes, neighborhood environment, including safety and health and healthcare. And we're making a difference. When the first 100 deaths from COVID occurred, the mayor went to her staff and said, what can we do? And they came with some ideas. She said, it's not good enough, call Westside United. And Westside United was brought in to partner with the city on the racial equity rapid response team that we just discussed. But now I'm going to hand it over to Pam, my colleague and friend from Amita Health.
Thank you so much, Dr. Ansel. The visual of the 16-year-old boy, of course, resonates with me since I have a son who'll be 16 in February. And the power of those statistics really is what motivates us to continue to try and impact our communities. And it was my privilege and pleasure to join Westside United and Dr. Ansel about 3 years ago to address economic impact in and on the west side of Chicago. And some of the issues that we've been focused on over the last couple of years have been around building economic wellness in socially vulnerable neighborhoods, addressing inequities, and providing for opportunities in procurement and hiring. And the goal is to reduce that life expectancy gap that Dr. Ansel presented earlier in the presentation. And the goal is to reduce it 50% by the year 2030. So as Dr. Ansel mentioned, there's 6 other hospital organizations that are working collaboratively. And that's so unique. And that's one of the things Dr. Ansel always talks about is the fact that these are actual competitors in the healthcare arena who have come together as a collaborative to focus on the same issues, because we know the importance of the collaboration and the impact and positive impact that it could have on our city of Chicago. So there are several pillars that are addressing the life expectancy gap. So one is to accelerate the hospital anchor strategies. We are often the largest economic impact provider in many communities. So we want to buy more from minority-owned, women-owned businesses. We want to develop local businesses. We were able to actually last year work collaboratively to give 30 businesses either funds to fortify their efforts to continue work in the communities or to provide them a startup. And it was a wonderful event to be able to partner with JP Morgan Chase to provide checks to these organizations on Martin Luther King Day this year. Also, another goal is to develop a local workforce and have workforce development, particularly from socially vulnerable populations. And then to coordinate all of our community efforts and facilitate hospital and community engagement strategies. We want to unite the West Side. So the West Side United really does play the role of a convener, and has had great success in, as Dr. Ansel mentioned, when COVID hit us really hard. One of the wonderful things about this collaborative and the racial equity rapid response team that Dr. Ansel mentioned was that a good example was right after some of the protests that had happened in the city, there were no pharmacies open on the south and west sides of Chicago to serve our most vulnerable. And so that team pulled together CVS and Walgreens on a call and said, what are we going to do to ensure that people are able to get their prescriptions and to be safe and healthy? So West Side United is an organization, I think, that's really providing a vision. We've been able to gain the support of Oprah Winfrey, who's made a large donation. Rihanna has made large donations, and others, because they really believe in this model. So some of the things that have led me from my participation in West Side United and being a diversity leader at Amita Health in the Chicagoland area is to look at reducing the health disparities and also build a culture of inclusion and equity that has been crystallized with respect to all the things that have gone on with COVID this year, as well as the social unrest that we're dealing with all across the country. And just to sort of frame it up, I know a lot of people say, well, what's the difference between health equity and equality? And I like to show this slide by the Robert Wood Johnson Foundation that shows that, people always say, oh, I treat everyone equally. But if you give folks that have different needs the same and equal bike, does it really provide equity for them? Is a person in a wheelchair actually going to be able to ride the same bike that someone who's really small or really tall able to? And so the bottom framework and illustration really shows the difference between giving someone what they really need to thrive. And so as a faith-based organization in healthcare, our bottom line is that health disparity is a violation of human dignity, and that unequal treatment due to race or ethnicity or anything else that makes us unique is a violation of human dignity. So as Dr. Ansel mentioned, with respect to COVID, thinking about the two pandemics that we essentially have going on now. One is the slow-moving generational pandemic that Dr. Ansel outlined with respect to inequities in food access, education, transportation, healthcare. All of those things have made COVID now that fast-moving pandemic that's really affected the socially vulnerable populations more profoundly. And so I'll never forget that prior to March and April, we were thinking of COVID as sort of a traveler's disease. But on Monday, April 6th, I'll never forget this, our mayor, Mayor Lightfoot, presented that data that Dr. Ansel mentioned earlier, that even though Chicago is 30% African-American, 72% of the deaths at that time were African-American. And of course, as many of you know, since that time, the positive cases of COVID-19 have risen disproportionately in the Latinx population as well. And so that's when the mayor then outlined that plan to provide that racial equity rapid response team. And so I started reading more from the headlines at that time and saw this alarming rate of infection and death amongst Black and Brown communities. And I immediately reached out to my chief medical officer and chief operating officer and said, what can we do at AMITA to address this disparity? And so they gave me the support and latitude to pull together a health disparities working group, where we did a root cause analysis, Dr. Ansel also. We looked at our real data, that's our race, ethnicity, and language data, to really try and understand the causes of disparities related to COVID-19. And then to create a plan, not to just examine it, but to try and address the disparities, and also to ensure that we fortified our community engagement to address the disparities. And so just as an example of the functional areas that were represented in this health equity task force, we had folks in analytics that were critical in pulling together this information about the demographics of our most vulnerable populations. But we also had two chief medical officers from across our 19 hospital healthcare system, chief nursing officer, people in our mission area that really provided a great context for some of the things that we were able to do as a result of our findings. And so, of course, being a community-based hospital organization, we started looking at the heat maps for COVID, and we really had to understand the unique needs of the communities that we serve. So we approached the methodology this way. From March 1st through into June, we looked at the total number of cases of COVID, the death rate and mortality rates, and some of the comorbidity information. We asked two questions. Do we see a disparity in the general communities in the Chicagoland area? And the answer was yes, we have Chicagoland data. And our response is we need more collaboration. And that's when we fortified our connection to many of our community organizations, including the Racial Equity Rapid Response Team. Then the second question was, do we see the same or any disparity that was reflected in the Chicagoland data within AMITA? And we found that the answer was yes in certain regions. And to address that, we needed to build an internal plan, expand our testing capacity, and provide cultural competence, guidance, and training, and do additional outreach. And of course, many of you, I'm sure, have heard and are living out some of the rationale for the disparities. There are living conditions, so folks living in densely populated areas. There's racial segregation, distance from healthcare facilities and healthy food access, and then people living in multi-generational households who just aren't able to self-quarantine. There are work circumstances, the critical and essential workers who work outside of the home that have more risk of exposure. You know, one of the things that we uncovered recently in our discussions was that even though there's ample testing, many folks who get tested still say they have to go to work, to pay their bills, to keep a roof over their heads. And so the luxury of a paid sick leave, or the luxury of, you know, being able to have all of the access and the essentials that they need to continue their lives have to go on with them going to work, even though they are testing positive. And then some of the other underlying health conditions are less access to care, lack of health insurance, distrust of healthcare systems, and that's really coming up quite frequently as we discuss the COVID vaccine. Then there are also language barriers that are really interesting for me as a language services provider in my system. And then also serious underlying health conditions that are contributing to the even worse outcomes for COVID. So some of the things that we decided to do to address the disparities, we thought of both internal strategies and then community efforts. So internal, we did more testing. We focused on cultural competency training so folks can understand some of the needs of our most vulnerable populations. We increased outreach as a follow-up to some of the guidance that we got from the Racial Equity Rapid Response Team in calling our most vulnerable patients who had been in the hospital for whatever reason to say, how are you doing? Do you understand COVID transmission? Have you followed up on your plan of action as you have left the hospital? And then we started to think about our underlying conditions, those comorbidities that were making the disease worse for our Black and Brown patients. And we were able to look at zip codes, particular zip codes, and focus on calling those folks to provide help around social determinants of health. So those community efforts. So the second phase of this is the community efforts. So more testing. One of our CEOs was able to align with one of our elected officials and actually go in and test in some of our senior facilities. We were able to do special access to food events like our farmers market that we had weekly at one of our hospitals that is in a vulnerable neighborhood. And then we've created a diabetes roundtable that has been born out of one of the most prevalent underlying comorbidities with COVID. And we were able to actually figure out a way to connect with the American Diabetes Association and a food pantry to get food access improvement to our most vulnerable population. So these are some of the other strategies that we're looking at. Transportation and housing, including isolation housing for COVID for our most vulnerable. This was just an example of some of the screening that we did to ensure that we addressed the folks that we were calling on a regular basis to check on their COVID symptoms and COVID education. And so we did that across those particular most vulnerable neighborhoods. And so here's the illustration of some of the things that we did. This is a picture of the farmers market at our hospital, Saints Mary and Elizabeth, that we started back in June and continued on through the end of October. Our cultural competency training will be ongoing. And then there's just the illustration of the testing that we did for our seniors. And then built out of that is we had a twofold action. So one was to address the immediate needs for COVID-19 that I expressed to you, but also to begin thinking about long-term ways to address our culture of inclusion and racial equity throughout AMITA. So we've created a statement of our commitment to inclusion, diversity, inclusion, and health equity that flows from our faith-based sort of framework of how we think about our patients and our communities. And then we are, as AMITA, a product of two parent organizations. One is Ascension, which is a Catholic healthcare organization that's in 20 states across the country, and including Florida, and Advent Health, which is also based in Florida, that is the Adventist base. And then those two leaders of those parent organizations made very strong statements about systemic racism. And Joan Pichike, who leads Ascension, said the hard work of eradicating systemic racism requires focused listening, prayerful contemplation, and action. And Terry Shaw, the leader of Advent Health, talks about it's no longer good enough to just personally acknowledge that we're not racist. We have to become anti-racist advocates. And so our leader at AMITA Health, Keith Parrott, has connected with those two messages and has been very supportive in creating actions in meaningful ways around addressing these inequities. And so we've established 10 recommendations of strategic initiatives that are going to address, we had our kickoff about 6 weeks ago. So we're going to put in our AMITA strategic plan key result areas in equity, inclusion, and diversity. We're going to develop specific goals. Our focus is going to be on diabetes. We've already created that roundtable. We're really going to be looking at how we can affect a change on our most vulnerable patients. We're going to have continued equity and inclusion dialogue sessions in partnership with our parent organization at Ascension. We're going to be looking at all our policies to ensure that they're not institutionally discriminatory. We're going to have continuous communication on our website that addresses inclusion and equity. We're going to continue our cultural humility training. And then our collaboratives like Westside United, and Senator Durbin in Illinois also has a similar initiative called Hospital Engagement and Leadership with some of the same goals as Westside United. And we are also focused on being intentional about providing opportunities for people of color in hiring and succession planning, promotions, and hiring from socially vulnerable populations. We have a connection with an organization called the Safer Foundation that prepares people who have just recently been incarcerated and are re-entering into the workforce. And so we have a direct pipeline with them to ensure that there are opportunities in our healthcare system for work there. We also have opportunities for enhancing our supplier diversity programs, where we've got capital plans that are going on now that are going to require a lot of coordination. And so we are pushing for a percentage of that work to actually go to minority and women-owned businesses. And then, of course, enhancing and creating recruitment and development plans for our medical staff. So I know we're running short on time, but those were the highlights of the work that has come out of the disparities that we've seen over the last several generations, but that have been heightened in our last 9 months.
Dr. Ansel and Pamela, thank you very, very, very much, not just for the report and the data that you shared, but for being people in your space and place, committed and dedicated, and who knows the personal sacrifices that you have endured and will endure to ensure that these missions continue to be at the forefront of our industries in Chicago and even into Jacksonville. Ladies and gentlemen, my takeaway right away from this is this: your skin color and your address should not be a determinant for your life or health outcomes. And that it's not enough to be not in favor of racism, but how do you become an anti-racist in this time and going into the decade? It's now your time to ask questions of these two wonderful people. The chat box is open. I can go to the chat right now and pull up some questions. Paula, am I okay to do that?
Yes, absolutely. And you should have some questions coming to you that have come in through the Q&A and through the chat.
All right, let's see what we have here. Trying to pull them up in my own chat. Let's make this a little bit bigger here. Question number 1. Referencing the work of Dr. Nadine Burke-Harris and Dr. Vincent Valetti, are you familiar with adverse childhood experiences and how it impacts minorities? Pamela, I'll come to you first.
So I'm a clinical social worker by trade. So definitely, I know that there's psychological trauma and socioeconomic trauma that many of our young people in our most vulnerable communities experience. And so, yes, that's something that I've been thinking about for decades. In the 90s, I was a clinical social worker at the University of Illinois Medical Center, and I was working with HIV positive pregnant women, and most of them had been either physically or sexually or emotionally or spiritually abused. Many of them had turned to substance abuse, and the intersection that I had with that patient population was existential. So at the time, we didn't understand the transmission of HIV from mom to baby, and we didn't understand life expectancy with this disease. And so it was a point of in that existential journey, people sort of having birth while they were facing death. And in that continuum that they had experienced many levels of trauma. So yes, indeed, that has been a part of my experience over the last few decades.
Dr. Ansel, do you want to respond to that question, or should I move on to question number 2?
Yeah, I didn't talk much about what we're doing internally at Rush, but we are actually, every pregnant woman is screened for ACEs, adverse child events, as is every pediatric patient in our institution. In fact, we've decided about 2 years ago to become a trauma-informed health system, because it's not enough just to ask your patients. Our staff has been traumatized as well. So this part of our sort of internal strategy around equity is to address these childhood adverse events, ACEs as they're called. So they're critically important. I just want to point out just 2 things in this moment. See, we have to address the needs of our patients, and that's what equity is all about. And the difference between an equity and a disparity is a difference, but an equity is a gap that's caused by injustice. So if that injustice occurs at the level of an individual patient or their family, it's our obligation as health providers to deal with it. But when the inequities are occurring also systematically in the communities, it requires us to go into those communities and simultaneously address those things as well. This has not been historically the vantage point or the action point of health systems. We think this is a new world that we must be in. So ACEs have to be addressed in our patients, but also we must get into community and address trauma where it's actually occurring.
Excellent. Question number 2. Many studies focus on general medical or primary care, which is commendable. However, has lack of access to dental care been considered as impacting health equity? I'll go to Dr. Ansel.
Yeah, I think there's multiple levels of care. Dental is clearly a problem, and we know medical outcomes are driven by dental problem, but also add behavioral health as well. There's, where there are gaps, they tend to be multiple gaps and systematic. So the same communities that have these low life expectancies that I described from heart disease and cancer are the same ones that don't have dentists available, or the same ones that don't have grocery stores. And at some point, we've got to ask ourselves, how could all this badness get concentrated in one place if there wasn't a force that was doing it? And this is where public policy can make a big difference. We have a health system. So because we live in a racialized society in which value has been attached from the beginning, before our country was formed, to the color of one's skin, the dollars follow that. And just bear with me for a second. So you can almost look at anything that's been racialized, and then white is on top and black and brown are on the bottom. And what that does is it's certainly the distributions of capital and resources, because most dental practices are private practices. They make money off of people paying or insurance. You can't go, most dentists will not go into Black neighborhoods. And so you add insult to historic injury. And that's how things like structural racism are perpetuated into the present. You do not need a perpetrator. So our form of capitalism, which is highly unregulated, perpetuates a system that values white and has resources in those neighborhoods available to those individuals, and devalues in general brown and Black neighborhoods and therefore people. So you have to look at that holistic lens, and then you can pick any health service you want, and it's going to be missing, dental included.
Excellent. Question number 3, within AMITA, how are you identifying and or addressing unconscious bias?
So unconscious bias in my training falls under the umbrella of cultural competence. And I don't really like to use the term cultural competence, because who's really competent in any culture? I don't know that I'm competent in my culture. I like to use the framework of cultural humility, which means being a curious and contemplative caregiver who listens to the patient needs and uncovers their own cultural awareness or cultural bias. And so that falls under that umbrella. So when I'm doing my my cultural humility training, it's really to say, okay, let's be aware of our biases. Let's be aware of our privilege. I go through an exercise called the privilege walk, which folks are able to take a few steps forward if they have the sort of thought of advantages in our society. So if you're right-handed, you take a step forward. If your ancestors were brought to this country without their consent, you take 2 steps back. If you had, certain educational materials, or you went to college, or your parents went to college, you take a few steps forward. And so that bias uncovering in that privilege walk shows so many people, so many different elements of their privilege and some of their biases. And within COVID, I've been able to do that training also online. And so I've been asking folks to give themselves scores of stepping forward or stepping backwards. So unconscious bias is part of that whole cultural humility, cultural awareness umbrella that I've developed in my training.
Excellent. And here's a question for you to continue talking and sharing. Do the hospitals contribute funds to the collaborative, quote, Westside United? Question. Dr. Ansel or Pam, address that. Does the hospital contribute funds? Okay.
Yes, they do. Rush, it's been under our fiscal agency at my institution, but we're operating under an MOU, and the hospitals that can contribute funds and other sorts of support, even in kind FTEs. We're evolving. We're about to become a 501c3, but likely tightly connected with the institutions. What I have to say about Westside United, because you guys are organizing down there in a similar way, there's first of all, we're historically competitors, but who's really competing around health and healthcare? We're all competing to do a better job of taking care of our patients, but it's never been really competing with each other. But we hadn't really been around a table like this addressing, the ideas that we're anchor institutions doing these things together. And being around the table, it turns out that the community engagement that we can do through Westside United is so much greater than we could do on our own. So there's a power in a collaborative effort. And we've set as a goal for this is to reduce the life expectancy gap between the Loop and the West Side by 50%. So we have measurable outcomes that we can all buy into. So I think we're buying into it in terms of putting some money into it. We're mostly bought into this conceptual idea of working together for racial equity and justice.
Excellent. I'm going to ask the next question from both of your lenses, one from a medical lens and one from a social work lens. First, the social work. Here's the question. I have met people who find the term anti-racist problematic. How can we get people to understand terms like anti-racist and white supremacy matter? Have you found people receptive to these terms? From a social work lens, what are you realizing about the words anti-racist and white supremacy?
So let me just say, my role as a clinical social worker has sort of evolved. So I'm really kind of looking at these things through a diversity officer lens, which has the tentacles in social work. So
excellent.
So my thoughts are that I've never really heard this language articulated as strongly as it has been over the last 6 months. And I know that people find these terms uncomfortable, but we are finding that these conversations that we're having in our core work groups around equity is that we have to be a bit uncomfortable and in our spaces right now. So we have to get comfortable with the discomfort because we have to talk about these things. Dr. Ansel talked about the fact that it took him up to a certain point in his journey to even be able to talk about these words. And so, and for me as a diversity officer to be able to go into a room and have these conversations with people who may not be in the minority, to really confront the fact that privilege has existed for hundreds of years in this country. And we have to come to terms with those realities.
Excellent. Dr. Ansel, from your medical officer lens, how do you handle or describe or explain anti-racist and white supremacy?
Well, it's a great question. And first, when people have a visceral reaction to words, it's an opportunity to pause and really get into a dialogue. But I want to just take it back to something I said before. See, it was the only way we could become a top quality hospital was if we took on the fact that harm was occurring in our patients. And we needed to sort of understand what was causing harm. And there's an old phrase in patient safety, what you tolerate, you promote. So if we had tolerated harmful events or risky conditions to exist in the hospital, and those things caused an inadvertent harm or death to a patient, and we ignored it, then we were never going to be a safe place. It's been part of so I'm saying this, so naming root cause and understanding there can be more than one root cause is a critically important step to fixing the problem. It doesn't fix the problem itself. So as I looked at health inequities and looked at these life expectancy gaps, and we know the national goal in this country is to improve life expectancy, and yet we're the only civilized, we're the only we're member of the most economically advanced countries in the world that have seen a drop in life expectancy. It's not just among Black people and brown people, it's among white people as well. We need to name the root causes in order to be able to begin to understand how we're going to fix it. But then so the worst thing you can happen is an event happens, people die early, prematurely, and have zero agreement on the root cause. So it's just important to be part of the discussion. No one dies when you say it, but if we're not attacking the solution at its root, we'll never actually improve to the degree that we want to improve, not only as hospitals, but as a country.
Good. And this question is also, I'm going to share this between the two of you guys. The data on life expectancy is so powerful. Pamela, have you been able to see an improvement in your area with your interventions? And then Dr. Ansel, I'll ask you, how long did it take to close those gaps? So Pamela, first half of this question, have you been able to see an improvement in your area, Chicago, with your interventions?
Actually, with COVID, it's still pretty bad. I think we're gonna see these challenges for some time because they're so long lasting and have so much of a historical context. I do feel like we're addressing it in a meaningful way, and we're just going to need some time.
Okay.
Dr. Ansel, I don't know how you feel about that.
Yeah. And Dr.
Well,
Ansel,
I'm going to
yes.
give you, why do we feel confident that this is the right approach? One is we got to give it time, as Pam says. So a few years ago, we took on the problem of Black-white mortality from breast cancer in Chicago, that Black women were dying 68% more than white women in Chicago, whereas 20 years before there had been no gap. And we took it on, and the approach we took went to every hospital in the city and got them to look at their quality. And when we brought them resources to improve their quality, and when they improved their quality, the mortality gap dropped in Chicago by 39%. And Chicago's the only city in the country that we've seen a drop in mortality, Black breast cancer mortality, simply by targeting quality improvement and navigating women with breast cancer into the highest quality care. Did the gap get eliminated? No. But did it get reduced? Yes. We know that much of the inequality in quality is driven in racial inequities in healthcare is driven by inequality and quality. And simply by focusing on those groups who need more, who may be getting worse care in their neighborhoods, we could improve it. That's one. Two, during early COVID, a group of institutions got into in Chicago and taking care of the homeless population by bringing testing into the community and other things. And we know in that population in Chicago, we had a big impact on mortality. Now, can you do it writ large across neighborhoods and communities? Yes, but you have to address the economic and educational conditions in those neighborhoods, because those are the two biggest drivers for life expectancy. And we know we can do it, but we have to understand capital of all forms has been removed from these neighborhoods over decades and decades. And first, the human capital is there, but it doesn't have the opportunity. But the social capital, all of us together, getting into neighborhoods and partnering with the community to do it together can make a difference. But finally, financial capital. These neighborhoods that are suffering from poor health outcomes have had capital removed from their neighborhoods. And so we need to have like a US Marshall Plan, like we rebuilt Europe after World War II, targeted at these neighborhoods that have been historically afflicted and oppressed. To me, it's a form of repair or reparation. And because when people have economic opportunity and educational opportunity, they live longer.
Excellent.
But we have to do it collectively.
And I know
And I
you've
think
got
our
some.
mayor,
Please,
just
go
one
ahead.
thing, Carl, I think our mayor in Chicago is very aware of all of these historical issues that need to be addressed and the economic impact. So she's been our mayor for a little over a year. So we're gonna ensure that we give her some time. Time is sort of the key element here.
Excellent. And glad to see the mayor of Chicago leading the way, as mayors ought to do in every major city and every small town across the nation. I'm going to give you one more question. I know that Dr. Ansel has some all important granddad duties, as we granddads often want to address. So here's the question. Given the links between physical health and mental health and the impact of COVID-19 on both, what have you done to address mental health in your communities? Pamela?
So that's a really, really great question. We actually, our Saints Mary and Elizabeth Medical Center, which is in the Westtown area, in what we consider our most vulnerable geographic footprint, has an inpatient behavioral health, actually 3 floors, I believe, in that hospital. And that hospital actually also is one of the largest Medicaid driven hospitals as well. And so we have fortified our efforts to ensure that there is accessible behavioral health care and testing and support for COVID. As a matter of fact, it's my understanding that some of the first therapies this week, I think it's the new COVID therapies that are coming on the market. Dr. Ansel, you'll have to help me with the name of it. But it's infusion therapy.
Yes.
We had our first patient on Tuesday in that hospital, in that community. So we do understand that that behavioral health and COVID and all the challenges that are connecting the two are heightened in these vulnerable communities. And our hospital, particularly in that area, is trying to address it in the best way that we can.
Thank you, Pamela. I'm going to allow you both 1 minute each to just sort of wrap up your presentations and your perspectives and your points of view, and we'll turn the call over to our team that will close us out for the day. So at the end of the day, we'll start, Dr. Ansel. I know you got to run, but
Well, I just want to say,
give us your 1 minute or so, my friend. Where is Dr. Ansel right now in your space?
I just got to say, why am I optimistic
Hmm.
in the midst of all of this moment? I have to say, when I sit around, and Pam will probably agree, with the Racial Equity Rapid Response Team around this table, with the mayor's office, with Westside United, with our community partners and our health partners, there's a huge amount of optimism that we can do this together, that we can solve these intractable problems, that these are the problems we need to solve. I'm optimistic because when I look back in history, uh, when the first abolitionists came forward and said, we got to abolish slavery, and everyone said, no, that's a stupid idea. Why don't we just sort of give the slaves a little more food and clothes, right? The abolitionists persisted, and we abolished slavery. I'm optimistic. And I think of Susan B. Anthony, who was arrested for voting in a federal election in 1872. Ultimately, it was many years, we got the right to vote. I just think that change occurs slowly. It's not like the issues that we're addressing are new, but there's a momentum now, and there's goodwill of people all around the country to really address these things in a systematic way. And so I think we should all be optimistic. I want to encourage the Jacksonville Coalition of institutions to leverage your collective power. And I want to encourage, the white folks and those who've been assigned to whiteness, as I got to be in this country, to use your voice to speak up about these systemic inequities. And it's not as if, white supremacy is the only inequity, but our voices are critically important. So thank you very much.
Dr. David Ansel. Pamela Boyd, wrapping up, baby.
Yeah, I do feel optimistic too. In working with Dr. Ansel over the last couple of years and being in these collaboratives, the optimism is palpable, even in the midst of these trying times. But I think what is standing out for me the most is my responsibility to address these issues, particularly as I am raising a Black teenager in the city of Chicago. And I'm responsible for him and the future. And stemming from what you saw from my parents made sure that they knew they were responsible to get me here where I am. And I feel the equal responsibility to address the issues of inequity and disparities because it's my responsibility as Pam.
Thank you. Ladies and gentlemen, again, we pay tribute to Dr. David Ansel and Pamela Mitchell Boyd for their commitment to this work. Just a privilege to know you both and to count you both as my dear friends. I now turn this call over to Paula Bides, the Director of Community Benefit at Ascension, Florida and Gulf Coast, to bring our calls to a close. Paula, are you on the call?
I am. Can you hear me?
Yes, I can hear you. Thank you, Paula.
Excellent. Thank you very much for your moderation, Carl. Wonderful. We appreciate all the speakers being here with us today, and we certainly do appreciate, on behalf of the Jacksonville Nonprofit Hospital Partnership, all of our attendees being here today. So this is the fourth of our four-part series talking about health equity. We wanted to bring this to the community as a gift of opening conversation. We know that health equity is a huge issue in our community, as it is across the nation now, and certainly racism being a significant part of that. We want to recognize that. So in these four-part series, we know we've talked about advocating for it, understanding it, listening, achieving it, and we want to continue this conversation. We look to have more additional community conversations, and in our upcoming community health needs assessment, which is not only required of nonprofit hospitals, but is the right thing to do, we have asked that we specifically look at racism being that public health issue that we've heard from Westside United and from Pam up in Chicago as their lens. So we're looking to explore that lens, and from that, continue that community conversation, continue that engagement and that advocacy, and bring some of that equity into our community as well. So I'll ask for next slide. So again, thank you for attending. For everyone who's been able to attend this one or any of the series of the 4, as we said, please look for more coming out. We certainly hear this as a call from our community. There will be a link to the recording, resources list, questions for anybody who wasn't able to attend. That's probably going to come out 2 to 3 days or 2 to 3 weeks post event. As well, we have a lot of wonderful questions in the Q&A we just weren't able to get to. So we are hoping to have those answered and sent out with that email. And we will have a survey there as well, where we greatly appreciate hearing your voice as we continue these conversations. The last bit of housekeeping I'll say is anybody who is here for CMEs, CEUs, who's on this call, we will be sending out communication and email. Please look for it between 24 to 48 hours will come out, and that'll link with instructions to obtain credits. That'll be sent to attendees. You will get CMEs through Mayo Clinic, and there will be some additional ones. Sorry, we don't have it listed. I believe it's therapist through Brooks Rehab, so those will come out as well. So with that, we'll close our presentation. Thank you so much for your engagement, and we hope to continue the conversation and continue to improve our community of Northeast Florida. Thank you.